All right, well, thank you very much for that kind introduction. Just to take care of some housekeeping here. I have no conflicts of interest, nothing to disclose, except that I am not a neurologist, neurosurgeon, or spine surgeon. And when I was asked to give this talk, I told them, this really isn't focused on that. But I was assured that the audience would be very interested anyway, so hopefully that's the case. And I will give a little trigger alert here. We are going to be sharing some really grisly photos and talk about terrorist attacks and explosive devices. This is my agenda. Whenever I start one of these talks, I always wonder, what am I going to fill this time with? And by the time I'm done, I find I'm cutting a lot of things out. So I don't think I'm going to get to all this, but I will try. Alan has given me a little extra time, which I appreciate. So in terms of lethality, the conflicts in Iraq and Afghanistan have been extremely costly. In fact, behind the American Civil War and the four big wars of the 20th century, the wars in Iraq and Afghanistan rank in fifth place in terms of casualties. And yet, the number of soldiers that are dying from their wounds is surprisingly low, less than 10%, which is better than any previous conflict. So why is that? Well, it is certainly not, Philip, help me out here. Do I just hit this button? It's certainly not from, all right, how do I get it to play, Philip? Yes.
If you click on
it itself? Okay, I got you. I'm doing it. Yeah, there you go. Well, it's certainly not for lack of effort on the part of our adversaries. The weapon of choice during this conflict was the improvised explosive device. I think Hollywood does us a disservice by showing guys getting blown up, and then the next scene they're dusting themselves off and then driving on. You can see here the convoys coming with their lights on, and unfortunately they're doing just what they're not supposed to do, which is bunch up right here. This vehicle then obligingly allows them to pass. And so that's a real improvised explosive device detonated, caught by a security camera mounted outside of forward operating base Taji back in 2005. And these are the sort of injuries they produce. The wounds are sometimes, the extremities are sometimes literally ripped off. And of course, there's often a complex extraction involved in it, and as you can imagine, pretty devastating results. And interestingly, before I was a physician in the Army, I did a number of other things. I was a tanker, actually, for a period of time. And on the bottom right here, we pulled this out of a soldier's chest. Unfortunately, he didn't survive the operation. But when I saw it, I immediately recognized it. So that's a depleted uranium round, anti-tank round. And early in the war, the Iraqi army sort of surrendered or backed away quicker than we could advance. And so Saddam had amassed these great stockpiles of ammunition and weapons, and so they went unguarded for a period of time. And during that time, they fell into the hands of terrorists, who then included them in their improvised explosive devices and turned them back on us. Well, one of the reasons that we have this low, this improved survival is the greater protection of our soldiers. Okay, so up in the upper left-hand corner, you can see this is the beginning of the war. They're still wearing the woodland camouflage vests here. This is really just a mild improvement over the old Vietnam flak jacket with some Kevlar instead of ballistic nylon. This is the IBA that has the ceramic SAPI plates, which can actually stop around. But this is what we end up with. This is the PASGT, which is a personal armor ground troop something or other. Anyway, much improved device, much improved protection for the soldier, with covering even the deltoids and the groin, which is pretty important. And the vehicles are much better. I actually took this vehicle from Baghdad to Fallujah, which is probably about the most dangerous road in all of Iraq. And these soldiers were running supplies between Baghdad and Fallujah, and this is just a thin-skinned Humvee like you see on any military base. Well, soldiers being soldiers are extremely innovative, so they got a hold of an arc welder and some quarter-inch boilerplate, and they just welded it on here to give themselves a little protection. Not a whole lot, slow down small arms fire, but not a lot. By the end of the war, we had these things. These are called MRAPs, or mine-resistant ambush-proof vehicles, thanks largely to Robert Gates, our Secretary of Defense, under both Bush and Obama. These were really just a dump truck chassis with a V-shaped hold placed on it, super armored up, very, very good device, very good vehicles against IEDs, not impenetrable, mind you. They'd still get blown up and we'd still get casualties from them, but a great improvement over this. Well, one of the other reasons that we've had an improved survival rate in this conflict is because of the innovations during the conflict itself. Now, care on the battlefield is separated into 5 different levels in the modern military. Level 1 is aid given by a buddy or a medic or a battalion aid station. Role 2 is where we first see surgical capability. This is in the form of forward surgical teams in the Army, CRTs in the Navy, or EMEDs in the Air Force. Role 3, is combat support hospitals. So these are fairly robust hospitals in theater with some subspecialties. But then role 4 is for the conflicts in Iraq and Afghanistan was at Longshore Regional Medical Center in Germany, and that's a very robust hospital. And then role 5 is stateside, or CONUS, as we say in the military. And these are like Brooke Army Medical Center and Walter Reed, where they have rehab facilities and everything else. And we don't have time to talk about all of these, but I'm going to try to talk about these mainly in role 1 and role 2 and 3 innovations that really improved our survival. And all of this falls under this rubric of something we call damage control resuscitation. So what is damage control resuscitation? Early aggressive strategy to prevent and treat hemorrhagic shock for patients with severe life-threatening traumatic injuries, usually in the setting of a massive trauma, massive transfusion. So this is basically, rather than getting into trouble in your resuscitation and finding your way out, this is staying out of trouble from the start. So rapid recognition of what we call trauma-induced coagulopathy, which is an entity that we've come to identify. Permissive hypertension, minimizing crystalloids, definitive control of bleeding, of course that's important. Prevention of hypothermia and acidosis. Ratios of product that approach whole blood, use whole blood when possible. And then point-of-care coagulation assays like TAG. And we're going to talk about some of these in just a minute. All right, now I think I did these questions wrong. I'm going to ask you the question and then I tell you the answer later. So rather than the way Alan did it. So I hope nobody's angry that they're not going to get these questions. Anyway, what are the 3 most common causes of preventable death on the modern battlefield? And then Philip, what do I do? Do I just hit this button forward? And then?
They'll just do it for you.
Again? Oh, there you go. I like this sound. All right. Oh, look at that. Oh, pretty good, not too bad. All right, A, exsanguination. Okay, that's been true since the time of the Romans and Greeks and probably before that. But preventable death, okay, so head injury and splenic injury are certainly causes of death on the battlefield, but we don't see a lot of this. The next one is actually tension pneumothorax, so that's number 2, and number 3 is loss of the airway. So, let me see, okay. So the military needs to have a problem it doesn't have a solution to. So the solution in this case was the IFAC, or Improved First Aid Kit. And this has in it the answer to the 3 most common causes of preventable death on the battlefield. Number 1, I'll get this to go forward here. Now, well, inside there, I had them popping up here, but for some reason, I think I did it wrong. Wait, maybe I go back. Oh, here we go. There we go. All right, that's the Improved First Aid Kit right there. Okay, so the first problem we said was loss of an airway. So they have a nasal trumpet. Admittedly, not a really great answer to loss of an airway, but in the hands of a 200-pound infantryman, that's better than nothing. Okay. Next thing is this scary-looking angiocath, which is in fact a good solution in the right hands for releasing the tension pneumothorax. But probably the most important thing is this right here, a tourniquet. Okay, and this is the combat action tourniquet, which we're going to talk about in a second, as well as combat gauze. And these were 2 very important innovations in this conflict. And you can see here these soldiers are all wearing their IFAC right there on their armor, just where they're supposed to. So the idea is you come upon a soldier who's wounded, you don't go into your IFAC, you go into his or hers, and take care of them. Okay, so tourniquets. Now this tourniquet is actually, this is my hand here. This was actually one that we had at Denver Health just recently, so it's clearly these are making it into the civilian sector eventually. So tourniquets, tourniquets have been around for a long time, since antiquity. This is a wood carving from, from the 1700s, and it shows the several tourniquets that were available. Now, admittedly, these were used in the operating room, not on the battlefield. But they've been around for a while, and they've enjoyed sort of waxing and waning popularity. Yeah. Anyway, they've enjoyed sort of waxing and waning popularity since the Civil War, and I hate to say it, but it's mainly the surgeons that have been against them. And that's because the surgeons were the ones who were seeing the damage caused by tourniquets in the operating room. Of course, for some reason, it was lost on them that the whole reason they were probably seeing that damage was because the patient survived long enough to make it into the operating room because of the tourniquet. But one of the things I've always said that if you want to know what's new and sexy in pre-hospital care during times of conflict, look to the Army. And if you want to know what's interesting, new and sexy in the Army in terms of pre-hospital care, look to the Special Forces, or units like the Special Forces, because they're operating autonomously, and they've been using tourniquets since Vietnam, really since Somalia in the early 90s. Tourniquets have had widespread use among those troops. Anyway, at the beginning of this conflict, we had the Combat Action Tourniquet, the CAT tourniquet, which is this device here. And this is really a wonderful improvement over the tourniquet I learned when I was in basic training, which you were only supposed to put on if you were willing to say that whatever's distal to that tourniquet, you're going to cut away in the operating room. Well, we use tourniquets in the operating room all the time, 90 minutes sometimes, and patients are fine. And if you can extract the patient soon enough, a tourniquet is a lifesaver. Okay, so this thing is designed, this is all Velcro around here, metal buckles through here, and inside here is a hollow sleeve that has a reinforced piece of nylon in here. So you put this thing on as tight as you can, and then this windlass is actually attached to the strap inside. You twist that thing around, and then this thing opens up, this little white strap moves out of the way. This thing opens up, and you slide the windlass in here, and then re-secure it, and then with your Sharpie or a little bit of the patient's blood, you write down the time that you attach the tourniquet. Very effective. And soldiers learn, and soldiers are great about training. So put a tourniquet on. If it doesn't stop bleeding, put another one on. And if it doesn't stop bleeding, put another one on. Okay, so sometimes we have patients show up in the operating room with 3 tourniquets on. Very effective. 2003, the Army Surgeon General said that CAT tourniquets were going to be standard issue. Every soldier who went to the theater of operations, most of us carried a CAT tourniquet in this leg and combat gauze in this leg with pockets down there. And now the research starts rolling in, okay? So this was a sort of landmark study put together by Colonel Craig. Here, Chuck Fox is actually a vascular surgeon at Denver Health, looking at the emergency use of tourniquets to stop major limb bleeding. Prospective observational study with a cohort analysis, 7-month period at Ibn Sina Hospital. Ibn Sina is the big hospital in the middle of the green zone that saw a lot of action during the war. 232 patients, a little over 400 tourniquets on a little over 300 limbs. Vast majority of these injuries were explosions. Pre-hospital tourniquets were applied on average 0 to 75 minutes with an average of 10 minutes. So what they found was that the real key of getting a tourniquet on is getting it on before shock sets in. Okay, so putting it in pre-hospital as opposed to the emergency room gave you a 13% survival advantage, but getting it on before shock kicked in gave you an 80% advantage. 92 is tourniquet versus no tourniquet. And this is their Kaplan-Meier curve, looking at, I think there was a subgroup of about 13 patients who had tourniquets versus 5 who had injuries amenable to tourniquets who did not have them placed. As you can see here, this is not the edge of the graph. This is actually what happened to the guys who didn't get tourniquets on. It's very effective. So how about that wound that you can't get a tourniquet on, a shot in the groin or a shot in the shoulder? How are you going to treat that? Well, that's what topical hemostatics are for. And early on in the war, they got a panel of experts together and said, what's the perfect dressing going to look like? So the dressing, the standard issue dressing in the military was a bunch of gauze with a couple of cotton straps around it, and pretty much unchanged since World War I. This conflict we wanted to go into with something a little bit more robust. So they said it's got to stop arterial and venous bleeding, no toxic side effects, ready to use without any training, durable, lightweight, flexible, operates in these extreme temperatures that the military deals with all the time, practical and easy to use, long shelf life, FDA approved. So the industry came up with 3 ways to make topical hemostatics. The first one are factor concentrators, basically just drying out the blood, okay? Getting the factors more concentrated. Procoagulants, these things either activate the clotting cascade or provide clotting factors in the form of fibrinogen and thrombin, and then mucoadhesives. These are generally chitosan-based. Chitosan comes from seashells. Seashells are mainly calcium. Calcium is good, as we know, for clotting. So the first generation were these two, King-Kong bandages. These were okay, 4x4 wafers, basically. The size was not really practical, and they were kind of rigid. And then we had quick clot granules. Okay, and this was a factor concentrator. The problem with these factor concentrators is they're exothermic. So you pour this inside a wound, and it generates some heat, which would often cause some damage. And if it's kind of like Ice 9, for those of you who remember Kurt Vonnegut. Once you get the clot going, you got to stop it, right? So that's not ideal. Now the second generation, WoundStat, again, it was another one that you poured directly in the wound, clay-based, again, exothermic, and eventually taken off the market. Celox was chitosan-based. These were flakes with a better surface area, and this worked pretty well. But this was really the thing that made a difference, combat gauze. Combat gauze was about a 2-inch gauze that was Z-packed like this, and it had this really opaque strip down the middle of it. Chitosan-based, it was also a factor concentrator, and this stuff worked really well. And so what you do is if you had a guy that was shot in the groin or in the shoulder, you get that, you rip open that pack and you pack it in there with your fingers, and then put a regular dressing on top of that. It worked very effectively. So it definitely slowed down. Third generation really is not a change in strategy or a change in technology. It was just kind of taking what we had and using them in kind of interesting ways. This was the X-Stat, which came in this syringe thing, and you would you basically inject this into a bullet hole that had these chitosan little tablets inside of it, and they would expand, which was pretty effective. So this is really translated into the civilian world in the Stop the Bleed campaign, which many of you may have heard about. Okay, this is really something that the American College of Surgeons got behind after a couple of these mass shootings, and the realization that a lot of these victims could have survived if somebody simply stopped their bleeding. And so we're kind of where we are a couple of years ago with AIDs. This is actually from my Boy Scout camp. And I took this picture here on the wall. It used to just be an AED here, but now we have this thing on top of it. A Stop the Bleed campaign, bleeding control kit. And inside here is, as you can see, our friend the cat tourniquet along with some other dressings. So we're getting the word out there to the public, Stop the Bleed. And I think a lot of this started in that with the military. So, okay? All right. So we're going to shift gears here now and talk about ratio wars, the ratio of products administered during resuscitation. So the historical background on this was that we used to always use whole blood, excuse me, for resuscitations, but by the late 1980s, component therapy, so packed red cells, FFP, had replaced whole blood as the standard resuscitation fluid. This was not because people thought component therapy was better than whole blood. This was mainly because of optimal resource utilization as well as reducing the transmission of infectious disease. But nobody asked the trauma guys whether this was a better idea, and it was not actually. And so we had these early resuscitation strategies, which in retrospect just seem crazy. But we put a couple of big IVs in somebody, give them a bunch of crystalloid, get them to the hospital. Once they got to the hospital, we'd only give red cells if there was a sign of ongoing bleeding or there were signs of shock. We didn't give FFP or platelets or cryo until we could prove to the lab that we needed it because the lab values were abnormal, or we hit some magic threshold, like 10 units of packed cells, before we give our first unit of FFP. So not surprisingly, we ended up with these crazy ratios of 4-to-1 packed cells to FFP. Okay? So not the best thing. So this is a landmark study from the war. It's called the Boardman study, looking at the ratio of blood products. Boardman, I think, was actually, I think Phil Spinola was really the guy behind this study. Well, what they did was they grouped about 250 casualties, again, I think mainly at Ibn Sina Hospital, into 3 groups: low, medium, and high ratios of plasma to packed cells. And what they found was that there was a clear improved survival in the higher ratios of plasma to RBCs. And so they concluded, well, they also pointed out that the guys who got a higher ratio of product had lower crystalloid administration and lower blood product administration overall. They also had, and this mortality, this improved mortality was preserved even in alternate analysis excluding these thoracic trauma, head trauma, whole blood, and in fact when we used to use recombinant factor 7A. And so this gave credence to the guidance that CENTCOM had already issued to combat support hospitals of trying to approximate 1-to-1 ratios in your massive transfusion protocols. So this is translated, not surprisingly, into the civilian sector. And there's a number of studies that came out during the war and after the war looking at blood product ratios. This is probably the most famous of them, the PROPER randomized control trial. PROPER stands for pragmatic, randomized, optimal plasma platelet randomized control trial. So I can't believe I remember that, but that's actually what it stands for. And this was headed up by the University of Texas, Houston, which is just a powerhouse of research in trauma. And what they basically did was they compared 1-to-1-to-1 products versus 1-to-1-to-2. And primary outcome, which was not really the ideal outcome, 24-hour and 30-day all-cause mortality. We'll talk about that in a little bit. Phase 3 trial, 12 level 1 trauma centers over about a 15-month period. You had to be included, highest level of activation, brought directly from the scene. You had to have at least gotten 1 unit of product in the first hour, and it had to be a massive transfusion, predicted to be either by Gestalt or by ABC. So ABC is a formula that was given to us by Tim Nunes and his team at the University of Vanderbilt. And basically, these 4 criteria, if you have, this is for now only a trauma activation, but if you have 2 or more of these criteria in a trauma activation, you have a pretty accurate tool for predicting a mass transfusion. So what did they find? Well, at first, very promising Kaplan-Meier curves here, showing about a 12% increase in survival at 12 hours and 22% at 30 days. Unfortunately, did not meet clinical significance. But the researchers cautioned you before jumping to that conclusion a couple of things. First of all, they only controlled the ratios of products for the first 24 hours. After 24 hours, the 1-to-1-to-2 group actually was then transfused at ratios pretty similar to 1-to-1-to-1. So the other thing was that hemostasis was definitely better in the 1-to-1-to-1, and death from exsanguination was better, was improved in the 1-to-1-to-1 group. My personal feeling is that the difference between the 2 groups was too close. 1-to-1-to-1 versus 1-to-1-to-2 is probably not that significant to see a difference in these outcomes. If they had the way we used to do it, 1-to-4, you'd probably see a much better improvement. So anyway, that was the PROPER study. Despite the fact that it didn't reach clinical significance, most people took away from this that this was an endorsement of the 1-to-1 transfusion protocol strategy. And what we do at our institution at Denver Health, 1-to-1-to-1 or thereabouts. And then once we hit hemostasis, we then go to lab-driven resuscitation, usually in the form of TEG baggers, well, entirely in the form of TEGs. So related to that subject is whole blood. The use of whole blood during these conflicts. Now this is the blood bank at Ibn Sina Hospital here, the quote-unquote blood bank. And really this was just 2 connexes or shipping containers attached side by side with the wall between them removed. And this was run by 2 junior enlisted folks. And when we had a massive transfusion, what we do is the unit, usually a neighboring unit, often the unit from which the soldier that was wounded was from, would send over a couple of truckloads of soldiers They'd open up the blood bank, they'd set up a bunch of chairs outside, set out some big screen TVs, because this is that generation. Put some TVs up there, the chow hall would fire up the grill and start flipping burgers, and you just start marching soldiers through the blood bank. They'd take off a unit of warm, fresh, whole blood, do a couple tests on it, and run it up to the operating room. So it's really a remarkable way to do a resuscitation. And of course, we found that this product was just amazing for resuscitations. About the time, okay, so here I got another question for you. Okay, so in the austere settings, such as the wars in Iraq and Afghanistan, what drives the medical community to go to whole blood as a resuscitation fluid? And the answer won't surprise you. Okay, Philip, am I doing this right? Like this?
No, it's okay. You got it.
Oh, I got it. Roger that. All right, so now I get this in. It's the need of platelets. Believe it or not. Isn't that interesting? Yeah. So it's actually all four of them. I mean, it's really all four of them. But the need of platelets, so you think about it. How good are platelets? How long are platelets good for? About 5 days, right? And even in the military, there's a robust logistics system, which is really robust. You think about it, you get your, extracting platelets is a sophisticated thing. Most combat support hospitals cannot do it. So you get your donor sitting there on the tarmac on a launch stool, you draw some platelets off of them, and you load it into an aircraft. That aircraft has got to go from launch stool down to Kuwait, and then tactical aircraft from Kuwait into the theater of operations. They're only good for 5 days. So at best, you're going to get 1 to 2 days out of those platelets. So it's really platelets that drives the use of whole blood. Now, these other things, of course, are important. But very true. All right, next one. Okay, so this is another tricky one. What does whole blood reconstituted using ratios 1 to 1 to 1 actually contain? So if you take packed cells, FFP, and platelets, mix them all together, what does it really look like? All right, here we go. I'm going to do this for real this time. All right. You got 8 seconds to think about that. All right, what do we come up with? All right, yeah, nice distribution. The answer is A. Yeah, believe it or not. So when you try to remake whole blood with component therapy, you end up with a very anemic, very thrombocytopenic, very hypocoagulable solution with a lot of extra stuff in it. D is actually whole blood. Okay, so that's blood coming right off a soldier and being taken upstairs. So yeah, so it's at the very most an approximation of whole blood when you try to do it with component therapy. So does this have civilian applications? Well, in order to do this in the civilian sector, we're going to have to overcome a couple of myths and challenges. Jesse, how am I doing?
Go back.
10 minutes, Roger. Okay, all right, I'm going to keep moving. All right, whole blood must be liquid reduced, which destroys platelets. Well, actually, our new we have filters now that spare platelets, so that's not so much of a challenge anymore. Cold blood storage of whole blood destroys platelets. Well, that is true, but actually a number of studies have shown that while it decreases survival, it may enhance aggregation over the short term compared to room temperature storage. But the big thing is you got to match ADO blood to the patient, right? Because we remember these diagrams. Okay, so for packed cells, this is the direction of transfusion. And for FFP, this is the direction of transfusion, right? So when you're giving whole blood, you're giving some O plasma with your blood, right? So you can't go that way, right? Well, not so much, okay? The fact is, there's something called low titer whole blood. In other words, checking the titer of how many antibodies that is in that blood makes a real difference. And armed with this information, who better to lead the way on this than the Army Rangers? Okay, so what they began to do, these guys have a special place in my heart. I went through Ranger School back when I was a young, crazy lieutenant. So what they do is always very interesting to me. What the Army Rangers are now doing is that every new Ranger that comes into the battalion gets they do blood typing on them. And all the type O Rangers are sent for additional antibody testing, titer testing. And then the platoon medic maintains a roster of all the patients' blood titer and last communicable disease testing, very important for Rangers, I'm sure. And then so using, this is from the Ranger Field Book, okay? So what they do is, so you get your soldiers here, 45% of them are going to be O, okay? So now you take that group, 70% of those are going to probably be low titer, okay? And those are your universal donors. So with these soldiers, and there was one or two of these incidents in Afghanistan where they actually did a soldier-to-soldier transfusion in an austere setting, dragging it off the one soldier and putting it in the other, okay? Then in very small print at the bottom of this, it says all universal donors will be voluntary. That's probably not even really the case. If I remember the Ranger School, there's no volunteering at all. All right. So the University of Pittsburgh kind of ran with this information, and Mark Yazzer and his team put together this pilot study level 1 at their level 1 trauma center. And what they did was they took 2 units of type O whole blood, stored in the ED, and for male trauma patients with a systolic less than 90 due to hemorrhage, an ABC score, our friendly ABC score greater than 2, so predicted to be a massive transfusion, they can receive 2 units of whole blood. They did no typing or screening, and then they looked at a historical cohort from 2 years prior. And what they found over a 10-month period, they got about 50 patients who received almost 2 units of blood each. 30 of these were non-group O, 5 they didn't know the type. No transfusion reactions. Plasma haptoglobin is a test that we do to see if there's cell lysis. These were normal, or actually a little below normal. Conclusion was that you can give a little bit of blood, of this low titer whole blood in the setting of trauma, and they're soon to begin a 4-unit whole blood trial here in a little bit. So as the op-tempo, thankfully, in Iraq and Afghanistan has slowed down, the DoD has turned to civilian trauma centers to continue their research, and they created this network of trauma centers to do something that's called LIGHTS. And LIGHTS is all of these trauma centers, and we at Denver Health are one of the core centers. University of Pittsburgh, not surprising, is another one, and then the University of Oregon. And so they're taking on a couple of studies. One is this 4-year prospective observational study looking at shock, whole blood, assessment of TBI. 900 patients, 6 sites. We're one of them. Denver Health is one of them. We're one of the component therapy sites as it would end up, hoping that whole blood transfusion in the setting of polytrauma has improved mortality and resuscitation outcomes. And then they're looking at how this is going to affect systolic blood pressure with a differential outcome in TBI's discharge at 6 months. Another trial they're doing, which is even more nascent, is this another prospective study looking at helicopter transport patients, giving them 2 units of whole blood on transport and then 6 units of whole blood earlier in the hospital care. So this study has not even got up and going yet, but hopefully pretty soon. So I'm going to shift gears. Am I doing fine? Okay, all right, I'm going to drive on. All right, I want to talk about ketamine a little bit for a second here. So ketamine, if the tourniquet is the medical device of the war in Iraq and Afghanistan, ketamine is the drug. Okay, this is a drug that has found all sorts of uses in the treatment of our soldiers. But what I want to talk about is the pre-hospital analgesic use of it. So who better to lead the way on this than the Rangers? Again, like I said, if you want to find out what's really sexy in the military in terms of pre-hospital care, look to these units like the Rangers who are often operating autonomously. 2009, the Rangers' mission changed. They were no longer doing these sort of short missions where they kind of go out, come back within 24 hours, but they were starting to do missions where they'd have to stay over for greater than 24 hours, 48, 36 hours. And so the PAs, who were always really sort of hard chargers in the Ranger Regiment, said, we want a more advanced pain protocol if we're going to be doing these missions. So the first line is the fentanyl lollipop, which is always very effective, but the second thing they wanted was a dose of ketamine. Here in their basic protocol, 250 milligrams IM, and here mixed with some midazolam, 75 milligrams IV, followed by POPs. So over a 5-year period, they looked at the soldiers who got ketamine, and what they found was that these guys were pretty badly hurt, so not surprisingly for Rangers, a lot of bilateral amputations and gunshot wounds, a lot of tourniquets applied. Some guys had as many as 4 tourniquets applied. But they found they were given some pretty whopping doses of ketamine. Average ketamine, 97 milligrams IV, 217 milligrams IM. And what they found was that there was not PTSD. Everybody assumed dissociative anesthesia. They're going to see a lot of PTSD. They did not see much of it at all. And very good pain relief. Being kind of new to use of ketamine, though, they were I think had some unexpected outcomes. This was quoted from one medic, because you can get pretty goofy on ketamine. The extremity movement made it difficult to move patients through heavy brush, and the incoherent speech was above normal speech. However, it's not known whether this caused unnecessary attention by the enemy. So good safety tip if you're going to use ketamine and the enemy shooting at you. Ketamine appears to be safe and effective, and they felt that it had a real use in the pre-hospital setting. Clear civilian applications. All right, so this is from our own university. This is actually a study done in a civilian EMS service, actually in Colorado Springs, comparing ketamine with fentanyl head-to-head, 0.3 milligrams IV every 20 minutes versus a pretty good dose of fentanyl. And what they found was 80 matched pairs, a pretty significant improvement in pain scores. So, all right, how am I doing? 1 minute, all right, well, I came in right. All right, well, I put a time check automatically in there. I think I'll take any questions at this point. Thank you. All right, I'm going to move on to the next subject because I broke this in here. So we're going to talk about blast injuries. There's not a lot of advance on this, except, unfortunately, on the other end, on our adversaries' end. We have a lot of these blast injuries, though. And they've gotten new and more dangerous. So right here, fuel air explosives, this is a scary development that the terrorists have figured out, and that's if you use 2 explosives in a big container of fuel, the first bomb goes off and disperses the fuel, then the second bomb goes off a nanosecond later and blows up the fuel. This is actually the vehicle that was found in Times Square in 2010. Fortunately, it never detonated, but this allows the fuel to wrap around corners and cause this awful explosion. Then this other thing called EFPs, explosively formed projectiles. This is a conical thing that you bury in the road, and when it detonated, it would drive this piece of usually copper metal up through the top of it, and it would form this projectile which could tear through armor, even through the bottom of the tank in a couple of occasions, which is just amazing. Blast injuries, the injuries from blast injuries are really 4, some say 5 parts. The primary injuries are from the wave, the second are from debris flying around, the third is getting picked up and thrown somewhere, and fourth is anything that's not covered in those first 3. So burns, exacerbated pre-existing conditions. Some have said that we should have a 5th group, and that's this delayed hypersensitive, hyperinflammatory response that we see. Sweating, hyperpyrexia, low CDP, despite resuscitation, which we see in a lot of these big explosions. So what happens, the way a blast hurts somebody, at least the initial blast wave, is what you get is this super increase in pressure. This is outside. Super increase in pressure. And then as that air is pushed away, you have a decrease in pressure. So then you get this implosive effect. And then it normalizes. Now, if you're inside a building or inside a vehicle, it doesn't move around. The air can't get pushed around, so you end up getting this bouncing back and forth of high and low pressures, which is much worse. Okay, so spalling is where you move spalling is where you move a more dense material to a less dense material. Implosion is where you do just the opposite. And inertia is the shear stress that's caused by a blast moving through an object rapidly of different densities. And as you can imagine, it affects all parts of the body here. Now, I think the interesting thing, and like I said, it's not like we changed the way we treat blast injuries very much during this conflict, but we just saw a lot more of them. I just remind everyone, this was a study often cited. Robert Kapoor and his group at the University of Washington put this together in 2005, but it looked at the blast injuries in the United States and the civilian world over a 20-year period. 36,000 blast incidents just in the United States, causing close to 6,000 injuries and 700 deaths. So it's not as uncommon as we thought. Am I doing that one? Okay. All right. All right, I'm going to talk about interosseous access really quickly. Interosseous access is something that really kind of came to, really became pretty popular during these conflicts, but not as popular as you thought. I'm sure everyone saw this article in the Journal of Royal Medical Naval Service 2014. Sitting in the bathroom right now, I'm sure. All right, interosseous access in the military operational setting. Okay, and they looked at these two devices for I/O access. The first is this fast one, this medieval-looking thing here. That actually doesn't create the interosseous access. That just holds this thing steady while you fire a spring out of here. And this actually goes into the sternum. And then this is the Easy I/O system, which is just a battery-powered drill and puts this thing either in the shoulder here or in the flat part of the tibia. And Vassello and his group looked at this and they found that they're pretty effective. 111 devices where the functionality was recorded, 17 had failed, 2 broke on removal but worked until they removed them. 84% efficient. Well, what they didn't include in here is how many of the IVs worked on these sorts of patients. So 84 is, I think, is pretty good for IV access in a combat setting. A little decreased functionality from compared to the Royal Army Medical Society's study a couple of years earlier. So how fast can you get product through these things? Well, this was a cadaveric study that looked at the speed of infusion that you could use here, and actually that awful-looking sternal device is the most effective of all of them, close to 100 cc's a minute. Okay, now this, of course, is crystal, right? This isn't blood or plasma, which can be a lot slower, but still pretty effective use. What I found interesting in this conflict was that we didn't see more IOs. This is the only IO that I saw. This little kid was wounded. He actually interacted. They cook almost everything in pots of oil. And this poor kid overturned the pot of oil and got badly burned. And he was brought to the gate of one of our operating bases, and we flew him down to the hospital and took care of him. He had a Snickers bar here that he would not let go of the whole time. And this is his dad here, who's seen some awful things. Anyway, okay, here's my last question. Are you a medic on patrol, your squad, and suddenly you're in ambush? Bullets are flying everywhere. A soldier nearby falls screaming with a gushing bullet wound just above his knee. What are your immediate actions? All right, so I'm doing it. I don't have the music. There we go. All right, we ready? Apply tourniquet. Well, people were listening at the tourniquet portion of this. Actually, the answer is okay. All right. So the best thing you can do for your casualty in a military setting is win the battle. Okay? And there's a reason that medics have more medals of honor than any other specialty. And that's because their training is to do this. When they see a casualty, they kneel beside them, okay? Start administering aid. This is, if you spend any time in the military and in medicine, this image is ubiquitous, okay? But the real answer is return fire, get the patient to a safe location, don't make yourself a casualty. This is updated, okay, so this was probably 10, 15 years ago, the way the image looks now. But this is what we're looking at now. Get the soldier to a safe location. I think a tourniquet is probably the first thing you do once you got them to a safe location, but return fire, get them to a safe location, and then use something very different from ABC. Okay, Chelsea, I know I'm over. Anyway, this is my summary. We learned a lot from these wars in Iraq and Afghanistan, and they have clear civilian application. All right, anyway, thank you very much.